Now, what is preterm labor? Yes, every student
Sir,
can answer this.
sir, it is a type of labor that is below
Before the labor.
before the time, sir, before 37 weeks of proper gestation. So it is before that.
Absolutely.
Before the time of gestation.
Absolutely right. Before the
Before
term.
37-week pregnancy.
Exactly. Before 37 weeks of the gestation, if the labor occurs or starts, we call that preterm labor. But remember, it has to be after 20 weeks. If it occurs before 20 weeks, what we call that? Yes?
Abortion.
Abortion.
Exactly. It is abortion. The term labor is not used there. Okay. So the proper definition would be if it occurs after 20 weeks of gestation and before 37 weeks of gestation, we call it preterm labor. Wonderful. So let's enter into the topic now. See here. Labor occurring between 20 and 37 weeks gestation is called preterm labor. Preterm delivery is the most common cause of perinatal morbidity and mortality all over the world. See this. Now, before I go further, tell me what is the meaning of perinatal period first? Yes?
Sir, it is a period of time, sir, when, sir, between pregnancy and sir, up to a year
Before
after
and
giving.
after the birth period is known as perinatal period.
Before birth.
Okay. So different types of answers are coming. Okay. Now listen properly here. Perinatal period is after 20 weeks again. Why 20 weeks is taken there? Because it's a period of viability. So period of viability has to be crossed. Then only it comes under perinatal mortality or morbidity or perinatal period. So after 20 weeks till, okay, after 20 weeks.
Sir, till 7 days after birth or 28 days.
Exactly. Till 7 days after birth, or some of the textbook even mention up to 28 days after birth. But till 7 days after birth is what many pediatricians believe is perinatal period. Okay, so don't forget that. Now let's come to the point. Whenever we analyze what is the most common cause of perinatal morbidity, morbidity is illness, okay, and mortality is death. What is the most common cause of morbidity and mortality in the perinatal period? We come to conclusion that preterm babies are commonly dying during this time. So preterm delivery is the most common cause of that. Many pregnant ladies will have preterm contraction but not be in preterm labor. So this is another important point. Just having preterm contraction doesn't mean she is in preterm labor. Okay, but we should be careful. Probably we should admit her in the hospital and monitor for the progress of labor. Regarding the epidemiology or how common it is, preterm labor complicates about 10% of the pregnancy. So it is commonly occurring all over the world. Now see there, let's go what are the types of preterm delivery, what are the categories of preterm delivery. Extreme preterm delivery is before 28 weeks or less than 28 weeks. Very preterm, less than 32 weeks or prior to 32 weeks you can say. Moderate preterm, between 32 to 34 week, and late preterm is from 34 weeks till 36 week and 6 days. It has to be before 37 week. That is the late preterm. So extremely preterm, prior to 28 weeks, very preterm, 28 to 32, see there. Moderate preterm 32 34 and late preterm 34 to 37. The prognosis depends on these categories. If some babies are delivered before 28 weeks, in many center they directly tell the parents there is a very very poor chance of survival, and this is a fact. Especially in the developing country, we don't have much facility to make those babies survive. But if the babies are delivered in this moderate preterm and the late preterm, most of them can survive these days. Let's move on. Now, what are the causes or etiology of preterm labor? Let's talk about that. Those are classified under 3 headings: maternal fetal, okay, fetal, and uterine. Okay, you can call it maternal also. Okay, fetal is given separately. So see this PPROM. Okay, this is premature. Okay, premature rupture of membrane. Preterm, premature rupture of membrane. This first P is for preterm, another P is for premature. So preterm, premature rupture of membrane. This is a very commonly used term in the obstetrics or the field of obstetrics. If 2 P's are not used, just 1 P is used, then this is called premature rupture of membrane. Okay. Right now we are talking about the preterm labor. So we use the term preterm, premature rupture of membrane. This is one of the common cause. Another is polyhydramnios. What is polyhydramnios?
Sir, it is excessive
Excessive amount of amniotic fluid in the amniotic sac.
Exactly. Okay, very simple meaning: excessive amount of amniotic fluid collection in the amniotic cavity. Good. Placenta previa, everybody know. Placental abruption or abruptio placentae or placental insufficiency, very commonly caused by PIH or pregnancy-induced hypertension. So these are some of the causes of preterm labor from the maternal side. From the fetal side, multiple gestation means twin pregnancy. Okay, twin, triplet, quadruplet. These are called multiple gestation. Congenital abnormalities of the fetus, like anencephaly, for example. Okay, anencephaly and fetal hydrops, swollen baby, swollen fetus inside. It may be because of severe congestive heart failure, okay, as a result of erythroblastosis fetalis, or maybe because of alpha thalassemia, severe anemia may develop there, and as a result of that, the baby may be born with severe edema. Another one is a uterine, okay, uterine causes. Now, what are those? You can clearly see there on the list. Incompetent cervix, excessive enlargement, okay, of the uterus because of polyhydramnios again, and malformations of the uterus like leiomyoma and the septate uterus. These are also very important. So let's, think a bit about them. Incompetent cervix means cervix is quite lax, it's not closing. It is remaining in the open state. So the baby can easily descend downward. So that is the meaning of incompetent cervix, one of the common cause of preterm delivery, as well as abortion. Excessive enlargement caused by a lot of amniotic fluid. It can again start the uterine contraction. Leiomyoma and septate uterus, there is not enough space in the uterine cavity, which may result in preterm labor. Now, let's proceed further. What are the risk factors and prediction of preterm labor? PTL is preterm labor. Okay, let's talk about the risk factor and what is prediction of preterm labor if those risk factors are present. If there is prior history of spontaneous preterm labor, okay, this is the most important risk factor. Prior history of spontaneous preterm labor. It can occur because of incompetent cervix. It can occur because of so many other, causes which we have just listed. So prior history of cervical excision or mechanical dilation can be a risk factor because of the damage done to the cervix. That cervix keep on remaining open. Okay, the cervix is not that tough now. Understand like that? There is one way to know the prediction of a preterm labor, and that is done by measuring the length of the cervix. So see here, cervical length measurement. It is measured by transvaginal ultrasound, and if they found the cervical length more than 30 millimeter, it has a high negative predictive value for preterm labor before 34 weeks. So let me clarify this again. From the transvaginal ultrasound, if they pick the length of the cervix is more than 30 millimeter, okay, there is almost very decreased chance of preterm labor prior to 34 week. But if the length of the cervix is less than this, okay, then there is a high chance of having preterm labor. That is the meaning. Another point, identification of bacterial vaginosis. This is caused by one particular organism known as Gardnerella vaginalis. Gardnerella vaginalis is a type of bacteria. So let me write that name for you here. Okay. Gardnerella vaginalis. N, okay, Gardnerella vaginalis. Okay, the treatment is metronidazole for you, and ureaplasma ureolyticum. It's a a similar type of organism like mycoplasma, and the treatment is erythromycin here. If these infections are there in the genital tract of the mother, then there is a chance of preterm labor. Okay, so we need to go for the treatment if these things are there. Okay, so let's move on. Now, one important question which may be asked from this topic, okay, please pay attention here, is the fetal fibronectin test. And this fetal fibronectin test is also one of the predictor of preterm labor. Now, what is this? So let's discuss about this. It's a type of glycoprotein which is present in amniotic fluid. So it is present during the pregnancy. It is also present in placental tissue, but we are concerned about the amniotic fluid now. This fibronectin is a protein that is believed to help keep the amniotic sac glued to the lining of the uterus. Try to understand this. The function of this protein is, okay, continuation of pregnancy. You remember like this. So how? It is helping the attachment of that amniotic sac on the lining of endometrium. The connection can be disrupted by an infection like endometritis, okay, or inflammation which occurs there, or if the placenta is separated from the wall of the uterus, okay, like abruptio placentae, or if the early uterine contraction develops because of so many other reasons, or if there is shortening of the cervix, if the cervical length is very short, all these causes, okay, can disrupt the connection of the amniotic sac with the lining of the uterus, and during this time the fetal fibronectin level will be higher, which can be tested, and if it is high, it shows that there is a chance of preterm labor. This is the meaning. Now let's come to the slide. This test is positive if it is more than 50 nanogram per ml. A positive fetal fibronectin test is a clue, okay, is a clue that the glue has been disturbed and the lady is at increased risk of premature birth within 7 days. So just remember this much. If fetal fibronectin test is positive, there is a chance of premature labor within short time. In symptomatic women means whenever they develop the uterine contraction, okay, before 37 week of gestation, fetal fibronectin is most effectively combined with ultrasound. US is ultrasound detecting the cervical length. If cervical length is not short and fetal fibronectin is negative, preterm labor is highly unlikely. So this is the explanation from the opposite way, isn't it? Okay, the opposite way. Or you can also say like this: if cervical length is shorter than 30 millimeter or fetal fibronectin level is positive, then preterm labor occurs or high chance of occurrence within 7 days. So because of this, this type of questions can be asked in the exam. Now, okay, we don't have enough time, so let's go through these risk factors. If these risk factors are present, there is a high chance of preterm labor, like multiple pregnancy, okay, twins, triplets, quadruplets. This is called multiple pregnancy. The chance is almost 50%. Uterine anomaly, septate uterus, uterus didelphi, okay, unicornate uterus. These are the different example. Again, there is a high chance. Premature rupture of membrane, high chance. History of previous preterm birth, high chance. Short cervical length, okay, less than 30 millimeter, high chance, but if less than 25 millimeter, definitely increased risk. And other risk factors like pyelonephritis, infection in the kidney of the mother, chorioamnionitis, infection of amniotic and chorion membrane, maternal smoking, heavy physical labor during the third trimester, polyhydramnios, abdominal or pelvic surgery, and any kind of inflammation and infection which occurs in the uterus. All of these are risk factors for preterm labor. We're talking about the different risk factors and etiology of preterm labor. Now look at this slide. It is again saying the same thing. A bit of revision for us. Excessive contractions before the term, because we are talking about the preterm labor now, that means before 37 weeks of gestation. Too much fluid or over distension, which is there because of polyhydramnios, extra babies or multiple pregnancy, ischemia. Okay, this is also known as, problem in the uterine blood flow, which is very commonly seen in pregnancy-induced hypertension. Placental abruption or abruptio placentae, one of the important cause of antepartum hemorrhage. Cervical factors, very short cervix or incompetent cervix which keeps on remaining open. Okay, then preterm premature rupture of membrane, very important cause. There is something known as uterine clock, which is maintained by the uterus. That means only after the lady reaches term, the contraction in the uterus start. This is a normal thing. If there is some problem in this, then preterm labor may occur because of the undue contraction or because of earlier contraction. Hormonal imbalance can also result that, and bacterial infection can also result that. Okay, so these are some other way of explaining the causes. Now see this another slide which will give you again a good concept. Decline in progesterone action, uterine over distension, okay, decidual senescence, decidua. What is decidua, by the way? What is the meaning of decidua? Yes, who can answer this? What is decidua?
Sir, decidua is the mucosal lining of the uterus.
Good, exactly. So what is the types of decidua? Do you remember? We have learned this long time ago. I'm not sure whether you still remember this or not. What are the types of decidua?
Decidua basalis,
The decidua basalis, the decidua capsularis, and the
Decidua
decidua
basalis.
paritalis.
Very good. Decidua basalis, okay, Decidua capsularis, and Decidua paritalis. Very good. Among them, the important is Decidua basalis. Now, if this Decidua basalis is, okay, deteriorating, or it is getting thinner, it is a bit decreased size than before, that is another important cause of preterm labor. That is called decidual senescence. In some of the lady, it may happen. Vascular disorder, which causes ischemia, infection, already talked about, like chorioamnionitis, okay, or endometritis. Cervical disease, like cervical incompetence, some prior damage of the cervix done by surgeries, okay, breakdown of maternal fetal tolerance. This is some sort of immunological factors, excessive stressful situation, a bit of overworking in the third trimester rather than taking enough rest, and some of the unknown causes. even after extensive history taking a physical exam or investigation, we don't know the cause. So these are some of the important factors. This is repeated so that you remember. If the teacher asks what are the causes or risk factors of preterm labor, you can answer in a confident way. Now, what are the clinical features? How we know that lady is in preterm labor? There is development of lower abdominal pain or feeling of excessive pressure there. Okay, that excessive pressure is felt because of descendant of the baby. Lower back pain also can happen. It is similar to the labor pain now, lower abdominal pain and lower back pain. And there is increased vaginal discharge or presence of bloody show. Show is a mucoid discharge with blood in it. This is called show. Everybody know that now. And this increased vaginal discharge may be because of rupture of the amniotic membrane. Particularly, okay, in primigravida, the symptom may be present for a number of hours to days, but are not recognized as contraction by the patient. They may ignore it. They may take it very lightly. Okay, they may not take it seriously, but it may be present for certain hours or even few days prior to the premature labor. Now, how to diagnose this? Okay, please pay attention. This type of questions are very commonly asked for the students. Two criteria need to be met. These are regular contraction 2 in 10 minutes. Okay, 2 contraction in 10-minute duration, and those are regular, and cervix is more than 2 centimeter dilated, 80 centimeter effaced, or there is a documented change in the cervix. Now see here, cervix is already dilated and effaced. That means the first stage of labor has already started with those regular contraction of the uterus. So the lady, if she is prior to 37 weeks of gestation and later than 20 weeks of gestation, we call it as a preterm labor now. Now, another diagnostic criteria is also there, and there are 3 criteria need to be met here. One is a gestational age, more than 20 to 24 week, but less than 37 week. Uterine contraction more than or equal to 3 contraction in 30 minutes now. Okay, so because of this duration, it is mentioned as a different criteria here, and cervical change has to be there. Okay, cervical change has to be there. So what type of change? We have to do serial examination of the cervix to see a change in dilation or effacement, or a single examination shows cervical dilation of more than or equal to 2 centimeters. So a bit of a similar type of criteria here, but because of the longer duration, the 3 criteria are needed in this situation. Okay, anyway, if these are present, we can strongly believe the lady is in preterm labor. Let's move on. Okay, now see here. So what can happen to the baby, okay, because of this preterm labor? We already talked about this. Okay, let's consolidate our knowledge regarding that by looking at this graph. See this: 24 weeks gestation, 26 weeks gestation, 28, 30, and 32. Look at the percentage of mortality here. Prior to delivery, okay, prior to 24 weeks, if delivery occurs, 80% chance of mortality. And when we move towards 32 weeks, the mortality rate drops to even lesser than 5%. So what is the knowledge, okay, or what is the concept we have gained from this graph is we should, okay, inhibit the preterm labor if possible. We should inhibit it. We don't allow preterm labor to happen, either because of some preventive aspect, or if it already the labor pain has already occurred, we can do something to inhibit that labor pain or uterine contraction so that labor would continue. This is the whole objective. okay, regarding the management of preterm labor. Now see this. So with this concept, okay, you already got the concept now. So let's go to the management. How to manage a case of preterm labor. So what we do in the beginning, what is the initial management? See here. Transfer to the appropriate facility if the C is stable. Appropriate facility means where there is facility to conduct delivery or the labor, where there are obstetrician present. You start hydrating her. Normal saline should be given, okay, at the rate of 150 ml per hour. You don't need to remember that. Just connect the normal saline or even lactated ringer there. Open the IV line and start it. Probably one bottle of normal saline is given for 4-hour duration, like that. Bed rest in left lateral decubitus position. This is the best position during pregnancy. Left lateral decubitus position. Don't ask that lady to lie in the supine position. What is the danger if she lies in the supine position all the time? What's the danger?
Superior vena cava syndrome.
There will be pressure on the vena cava muscle.
Vena cava syndrome.
Return to the heart.
Superior vena cava
Gravid
compression.
uterus will compress the superior vena cava.
Exactly.
Less venous return.
Exactly. This is the compression of inferior vena cava. Okay. This is also known as supine hypotension syndrome. Supine hypotension syndrome because of compression of the inferior vena cava by the enlarged uterus. But if the lady lies in the left lateral decubitus position, the chance is not there. Give sedation by morphine. Okay. It will relieve the anxiety. Avoid repeated pelvic exam. Avoid it as far as possible, but if they are necessary, you need to do it. Maintain strict aseptic precaution. If you do it multiple times, there is increased chance of infection. Do ultrasound examination of the fetus. Make sure what is the gestational age of the fetus, what is the condition of the fetus there. That is known by biophysical profile, also known as BPP in the short form. This biophysical profile test may include a non-stress test with electronic fetal heart monitoring and a fetal ultrasound. Just remember the concept here, okay? This test is done to know whether the baby is normal there or not. What is the fetal heart rate? Is the baby in fetal distress or not? So make sure the baby is not in fetal distress. What is the position of the baby? What is the location of the placenta? And what is the estimated fetal weight? All of this information is provided by ultrasonography. So do it. Make sure, okay, the baby is normal there. And what is the weight of the baby? Let's find it out. How many babies are there? Let's find out. What is gestational age? Let's find out. So everything is done by ultrasound. And then use prophylactic antibiotic, okay, especially if there is a premature rupture of membrane. Otherwise, it is a controversial thing. Okay, let's move on. Now, the second important part of our management is suppression of labor, which is known as tocolysis. A suppression of labor known as tocolysis. I'm sure many students know this term from pharmacology. See here, what is the principle of this tocolytic therapy? It doesn't inhibit preterm labor completely, but it may buy time for us. Okay, it may buy time for us. It is used for less than 48 hours to allow for betamethasone and or transfers to the appropriate center for care of the premature infant. Now let me clarify this for you. So tocolytic drugs are given, okay, to buy time for us. Whatever has happened, probably we cannot inhibit that for a longer time. We cannot completely abort that, but we can buy some time for us to give betamethasone drug to the mother. What is betamethasone? What type of drug is this?
It is a corticosteroid, sir.
It is a steroid drug.
Moderate active corticosteroid.
Good. This is corticosteroid. Actually, it's a long-acting, okay? Betamethasone and dexamethasone. These are the long-acting corticosteroid. And why we give it? This is the important point you need to remember here. This is given for the fetal lung maturity. Remember, one important point which I discussed before, at 34 weeks of gestation, there is, development of surfactant. The surfactant will be present by that time. So if a baby is delivered prior to that 34 weeks of gestation, there is no surfactant inside the baby's lung. Without surfactant, the alveoli will be collapsed after the birth when the baby tries to breathe, and the baby will develop hyaline membrane disease. To avoid that, if we give betamethasone, okay, or before 48 hours of the delivery, especially in preterm labor, the fetal lung will be matured because this betamethasone will stimulate the formation of surfactant there. And even if the baby is delivered after that, the baby would be safe from hyaline membrane disease. This is the reason why we give betamethasone here. Okay. Now, what are the requirements? All must be satisfied for this tocolysis. So see that, please. One is preterm labor, and the definition is prior to 37 weeks and after 20 weeks if there is a regular uterine contraction. There is a live immature fetus. There should be intact fetal membrane, and there is a cervical dilatation of less than 4 centimeter. Then only you can go for tocolytic therapy. And there should be absence of maternal or fetal contraindication. And these are the contraindications. Okay. Regarding the maternal one, bleeding like placenta previa or abruptio placentae, maternal disease like hypertension, diabetes, or heart disease in the mother, or if the mother is in heart failure, preeclampsia or eclampsia, and presence of chorioamnionitis. You don't give tocolytic therapy in this situation. That's the meaning. That's why they are listed as contraindication. There is a harm. We don't delay delivery during this type of conditions. There is a serious problem done to the mother. Regarding the fetal contraindication, erythroblastosis fetalis, severe congenital anomaly like anencephaly, for example, fetal distress or fetal demise, the fetus is already dead, IUGR baby, or multiple gestation, that may be a relative type of contraindication. During this time, you don't stop, okay, the uterine contraction by giving tocolytic therapy. That's the meaning. Let's move on. Now, what are those tocolytic drugs? See here, what are these drugs for us? So they are classified under different types. Very important questions from the exam point of view. So please pay attention here. These are the tocolytic therapy or tocolytic agents. Means they relax the uterus. They don't allow the contraction to come easily. The first group are calcium channel blocker, and nifedipine is a good example here. Okay, this nifedipine can be given for the tocolytic effect. You don't need to remember all these doses and things like that. Okay, just remember the drug name. Second group, prostaglandin synthesis inhibitor like indomethacin, because prostaglandin also leads to contraction of the uterus. The third drug is magnesium sulfate. Okay, magnesium sulfate. This is also a very important drug in the treatment of eclampsia. Now, what is eclampsia? Probably I have explained somewhere before.
Induced hypertension.
Pregnancy-induced hypertension with seizure.
Pregnancy.
Exactly. I already got the answer. Pregnancy-induced hypertension with seizure disorder is known as eclampsia. Excellent. Okay, so this is a serious situation. And magnesium sulfate is the drug which is used in the treatment of this condition. The same magnesium sulfate can, cause uterine relaxation as well. And salbutamol, terbutaline, ritodrine, and isosuprene. These are called beta agonist drug. Okay, to be very precise, beta 2 agonist, and they can be used as a tocolytic agent. So remember the name: calcium channel blocker, prostaglandin synthesis inhibitors like NSAID, indomethacin is a good example, magnesium sulfate, and salbutamol. Now, the third important type of management of the medicine which we give here is betamethasone. Okay, betamethasone. A third important step in the management, I should say, is betamethasone. Now, I already explained what is the purpose of giving this betamethasone here. It is to enhance the fetal lung maturity. After fetal lung is matured, even after the delivery of that baby, okay, the baby is safe from respiratory distress syndrome, also known as hyaline membrane disease. So betamethasone is given like this: 12 milligram IM, okay, every 24 hours for 2 doses, or you can go for dexamethasone 6 milligram IM every 12 hourly for 4 doses. So anyhow, 2 doses are necessary now. That's what we mean, 2 days, 2 days means 48-hour time we need for the lung maturity of the baby. If the lady comes to us with a regular contraction of the uterus and we believe she is in preterm labor, let's start betamethasone or dexamethasone as soon as possible, so that even if the baby is delivered, the baby is safe from hyaline membrane disease. So from 28 to 34 weeks gestational age, okay, it reduces the incidence of respiratory distress syndrome, RDS. 24 to 28 weeks gestation, it reduces the severity of RDS and overall mortality, and even the rate of intraventricular hemorrhage, IVH, intraventricular hemorrhage, is decreased a bit. Okay, and it is not used if the mother is having active tuberculosis, because in the presence of steroid, tuberculosis will be further progressive. We say TB will get flared up in the presence of steroid. So steroid is contraindicated in active TB. But how many ladies are developing active TB during pregnancy, isn't it? Very few. So you can almost forget about it. But remember, the important use of betamethasone or dexamethasone is fetal lung maturity. Now you may be wondering, I'm constantly explaining fetal lung maturity, fetal lung maturity. What does that mean? That means surfactant. So let me clarify a little bit about the surfactant here. The surfactant, okay, has lecithin and sphingomyelin. Lecithin and sphingomyelin as the very important components. Lecithin and sphingomyelin. Now, this lecithin and sphingomyelin, okay, ratio, also known as L-S ratio, lecithin to sphingomyelin ratio, should be more than 2. Okay, should be, more than 2, okay, to 2.5 in a normal situation. What does that mean? That means if the fetal lungs are already matured, and if we take the amniotic fluid out and check for lecithin sphingomyelin ratio, it should be more than 2 to 2.5. If the fetal lungs are still unmatured, or if surfactant is not properly formed, LS ratio is lesser than that. Okay, so betamethasone and dexamethasone will help in earlier maturity of the surfactant, or earlier development of the surfactant, so that baby will not have any problem after the birth. Let's move on. Now, another type of management we can do is the cervical cerclage. Now, cervical cerclage is done in case of cervical incompetence. Remember, cervical incompetence is one of the important cause of premature labor. See this, okay? And cervical incompetence means the cervix is, not contractile enough. It is not tighter enough. It is remaining as a dilated form, or the effacement is already developing. This is the meaning. So we need to put some suture there, okay? We need to put some suture in the cervix so that that cervix can hold the baby inside the uterine cavity. It doesn't allow the baby to descend downwards before the necessary time. This is the purpose of cervical cerclage. So placement of cervical suture at the level of the internal os, usually at the end of first trimester, and it should be removed in the third trimester to allow the delivery to occur, is known as cervical cerclage. Okay. Now this cervical cerclage has got different terms there. If there is some time for us, we'll talk about that in the subsequent classes. Some important sutures are put there, okay, like McDonald suture and Shirodkar suture. These are the different things we put in the cervical cerclage. Let's move on. Now, how to diagnose the cervical incompetence? How to diagnose it first? It is diagnosed by obstetrical history. Now, let me ask you one question. If a lady is having cervical incompetence, abortion can occur in first trimester or in second trimester. Yes, we talked about this before. In which trimester abortion will easily occur because of cervical incompetence? Anybody? Yes?
Sir, mostly in a second trimester
First
because
trimester.
due to
Sir, in
the,
second trimester.
because baby size increase was, but due to cervical incompetence, there is a chances of increase abortion.
Absolutely. Both of them are answering in the same way. Very good. So this is in the second trimester. So never forget this. This is a very, very important question your teacher can ask you. In second trimester, one of the commonest cause of abortion, okay, of course, before 20 weeks, definitely, is cervical incompetence. So that is the clue we get from the obstetrical history taking. Ability of the cervix to hold an inflated Foley catheter during a hysterosonogram is another evidence of cervical incompetence. Now, Foley catheter has a balloon near the tip. We all know that. Okay, see there. It has a balloon. When we inflate that balloon, okay, with a 5 or 10 mm, okay, or ml, I should say, ml of the water or cc of the air or whatever, it will get inflated. And if it nicely fitting on the cervix, that means cervix is already dilated. Okay, it is already loose enough, which is an important point in cervical incompetence. Okay, hysterosonogram is the term we use for the investigation of uterine cavity by these things. Now, there is a proven benefit in the prevention of preterm labor in women with primary structural abnormality of the cervix, and that is done by conization of the cervix or in connective tissue disorder. These are the two important causes of cervical incompetence. Conization means cone biopsy, we say, is a very big chunk of tissue maybe taken out of the cervix for investigation purpose, and after that the cervix become incompetent, or as a result of some connective tissue disorder like Marfan syndrome, Ehlers-Danlos syndrome, for example, again cervical incompetence may be developed. So there is a definite role of suturing the cervix by McDonald suture or Shirodkar suture. We are coming toward the end of this important topic. What is a prognosis, okay, of this management? Prematurity is the leading cause of perinatal morbidity and mortality. There's no doubt about it. I already told you in the beginning of the class. So if we can prevent the premature labor from happening, we are doing whole lot of good things for the community, okay, and for the country itself. 30-week or 1500 gram means if the baby is delivered at 30-week or around 1500 gram weight, okay, there's chance of 90% survival. But if the baby is delivered after 33-week or around 2 kg is already there, there is 99% survival even after preterm labor. This is a very, very good data for us. But if the baby is delivered prior to 28 week, okay, or before 1 kg weight, then the mortality rate is very, very high. Very high. Okay, so these are the important points. See here. Now the last part, can we prevent preterm labor? Can we or not? Yes, we can. Okay, so for this, this is a whole lot of discussion actually. Okay, a bit of preventive aspect of the medicine. So the preventive measures can be good prenatal care. Okay, good prenatal care or antenatal care. The lady, when she knows she is pregnant, should visit the obstetrician. Okay, and how many times? How many times you know is called the normal antenatal visit in a pregnancy? How many times? Anyone?
Sir, 3 times.
So 3 times is your answer. Anybody else? It is 4 times. Okay, at least 4 times. I will provide you that class of antenatal care, you know, a bit later. That is a long class, but most of the things we have already discussed. That's why I don't want to discuss it again because we are a bit of running short of time. But I will provide that lecture for you. So remember, in a throughout the duration of pregnancy, at least 4 visits has to be there in the antenatal clinic. 1 in each trimester, because there are 3 trimesters in pregnancy, and 1 visit should be just before the expected date of delivery. So 4 visits should be there. And during that time, good prenatal care has to be provided. Identify the pregnancies at risk. Treat the silent vaginal infection or UTI and give good education for the patient. And that education should be after 20 weeks. If you develop abdominal pain, visit hospital soon. If there is rupture of membrane and leakage of amniotic fluid, go to the hospital quickly enough. If there is any signs of infection or fever there, go to hospital soon enough. Okay, avoid from excessive labor type of work. Take enough rest. So these all are important patient education. Another one, transvaginal ultrasound of cervical length is recommended only for high-risk pregnancy, not to all. And that is if it is less than 30 mm, there is a risk of preterm labor. If the length is less than 25 mm, definitely high risk. Okay, so all of these are important management issues here. With this, let me stop here today. Okay.